what chenodeoxycholic acid does every day in every human being. So it's a really potent increase. And since it's a bile acid, it follows the course of absorption that we have for bile acids. It goes into the liver, it's processed, it comes back out in bile, and it's reabsorbed. It follows a big circuit. So it has this ability to get in and to penetrate and to enrich itself where it needs to go. Now, it clearly has impact on bile acids. It decreases the amount that are being synthesized. And so cholestasis, the stasis of bile, becomes less toxic because bile acids of other types are toxic to the cells. It will increase secretion of bile, meaning that you flow bile and wash out things. And it will decrease the absorption and reuptake of the bile acids so that you don't try to replenish the pool. It also is a great anti-inflammatory effect, and it decreases the ability to scar. Those are exactly what we would like, right, for an inflammatory disease that scars the liver, and it's doing so through cholestasis. So it really hits on all cylinders. So it's a very interesting molecule that we're endowed with to have all of these properties in every person every day. Now, this is another one of those boring slides, but without it, we can't get our footing. This is kind of like your table of contents. OCA Clinical Studies. I'm going to share with you the phase 2 studies, which was monotherapy, meaning nobody took anything other than OCA. They didn't take any URSA. As well as those that took OCA plus URSA or a placebo, and PBO is placebo. Now, these were very short studies, as you'll see, but they went into ongoing extension. Why is that important? It means that in the ongoing extension, you have people that have been treated and monitored for 5 to 8 years on OCA. That's what it means. Now we switch over to the phase 3 trial. This is the one you've all heard about. This is what was approved by the GI Drug Advisory Committee on April 7th of this year. And as Carol mentioned, I was very honored to be part of the presenting team there. My job was to wrap it up and to talk about benefit and risk. And there's only one other 17-0 vote that has occurred in the last 9 years. So we were 17-0. So I think you know that the committee has your back. And they recognize that this is something that's 35 years in coming. And then we have a very important study, which is a phase 4 study. This is a study that is required by the regulatory agencies to validate those endpoints, that alkaline phosphatase is an excellent endpoint that will predict how an individual patient is going to do. That's a study that's currently enrolling. It's been enrolling since February of last year. The enrollment, however, is extremely slow. So here's the placebo, and you can see we're in a 3-month study frame. People got 10 milligrams and they got 50 milligrams, and this is the monotherapy group. They had to have the diagnosis. They had to have a lower bilirubin, not above 2, and they could have alkaline phosphatase that could range widely, and they couldn't have taken any URSO for 3 months or more. So those were the 3 groups. If you look at the primary endpoint, which was the % change in alkaline phosphatase, you saw that here in the 10 milligram group, there was a 45% decrease in that 3-month period of time. And for the 50 milligram, it was less. So it immediately tell you that more drug didn't get more effect, that you were doing quite well at 10. Now we're going to look here at the proof of concept as an add-on to where you had URSO, you had the diagnosis, but your alk phos remained elevated despite the fact you were on URSO. You could still have a bilirubin, but it had to be within a lower kind of range. You couldn't have the history of being in that decompensated group where, you know, the horse was in way out of the barn, which increasingly is rare in patients in this country. And you had to be on a stable dose of ursodeoxycholic acid for 6 months or more. Here's the placebo group. 10 milligrams, 25 milligrams, 50 milligrams. Okay? So here is that percent change in alkaline phosphatase. Nothing really happened with the placebo group. 24% decrease. Remember, they already had a decrease due to URSO. Everybody responds somewhat. 25% at the 25 milligrams and 21% at 50. So clearly, there was no advantage above 10 milligrams. That was the key take-home message. If we then looked at the durable response out over 5 years, you could see that you had all subjects here, and you had those that had no UDCA, their alkaline phosphatases had achieved those downward trends and they locked in. It was durable. You can see the same thing when you add on, you come down. Remember, this is the 3-month point. This is the study I just showed you. And then, over time, you basically were either a slightly downtrend or a horizontal flat line. So the 5 years showed it was durable. Now, the majority of the treatment emergent adverse events, don't you love terms like that? People that had side effects. That's what we're talking about here. In the placebo group, monotherapy, and in the add-on group, these are the 2 different studies in each of these little graphs. You can look at the major one was pruritus. Nice Greek word for itch. So it was itch. And you can see by the percentages that the higher the dose, the more the itch. So this also was important. It meant that you're going to get less itch if you go to the low dose, but you got the effectiveness at the low dose. So that's the important message that was taken into the phase 3 study. This is the one that the FDA just had approved. Now, in this study, I'm not going to belabor the fact that a very complex endpoint was made because the FDA decided that it was better to simplify the endpoint and focus entirely on alkaline phosphatase. But the design was very important. It was placebo. It was 10 milligrams from the get-go. And another group, equal in size, was titration. They started at 5 milligrams. And at 6 months, if they had achieved the response less than 1.67 and maintained normal bilirubin, or achieved normal bilirubin because both were in the study, they stayed on it. If they hadn't achieved that, they up-titrated from 5 to 10 milligrams. Is that clear? So this is a way of looking at how you can start treatment and end up with that optimal dose of 10 milligrams. So the endpoints, again, I'm not going to go into because they slightly changed. We had the characteristics that this was dominated by Caucasians, dominated by women, as the disease is predominantly a disease of women. The age was comparable across the spectrum there, and we had significant numbers of people who were 65 years of age and older. Again, a testimony to the delay in any kind of progression that's been going on over decades of the use of URSO. Now, again, the baseline characteristics, we had the vast majority using URSO. There were some, you can see the percentages here, that weren't. They were going to get monotherapy. The daily dose of URSO was right on target, 13 to 15 milligrams per kilogram per day. You can see they were right where they should be. So you couldn't criticize this and say, oh, they didn't respond to URSO because they didn't get enough. They hadn't been adequately treated. Well, yes, they had been adequately treated. They just hadn't adequately responded. Their alkaline phosphatases, you can see, were generous in the 300 range. Then those that were 3 times the upper limit of normal, were ranging from about, a quarter up to a third of patients. Bilirubin, this is in micromoles per liter. Forget it because we don't use micromoles per liter, so don't worry about that. And then we had patients with cirrhosis. Remember what I told you, that it's not an endpoint, it's a process? 12%, 10%, 5%, 9% in the different groups. So we had the spectrum of U.S.-based disease. So you can see each of these, and I just sort of went through them without remembering that it had the build. So let's get to the endpoint. This is the response rate. The majority of this endpoint is ALK phos falling beneath 1.67 times the upper limit of normal. Now, just for rough, mental math, the endpoints are different based on the upper limit of normal, but most of your upper limits of normal will put 1.67 right around 200, 205. Remember, the average was about 350 in the people that enrolled. So you found that 10% of the placebo fell and made an endpoint, 45% in the titration group, 46%, 47%, and these were all statistically significantly much better than the untreated placebo group. What about the characteristics? Well, these are very interesting kind of graphs, and for us, for you, it looks like a mirage. We have right along this dotted line something that would favor being on the placebo, meaning the drug didn't work at all. And then this side, it would be favoring OCA. So whenever one of these little bars of the confidence intervals, we call them, does not cross that line, it means that all of these were statistically in favor of a response to the drug. And it was independent of what your baseline bilirubin was. It was your baseline alkaline phosphatase. They all came under the favoring of the drug, whether you were male or female, the age, less than 50 years, greater than 50 years, or whether you're using URSO at baseline or you were not using URSO at baseline. So you can see everything said that there was a positive response to the therapy. So what does it look like when you look at it over change? Here's 0, baseline, and then you have these negative changes done as decrements of the actual values of the alkaline phosphatase. Here's week 2, here's 6 months, here's 12 months. And so you can see placebo is right here. Nothing really happened. If anything, you could say that maybe there was a slight uptick because that slope is going up. It's not completely flat. And here's the treated group at 10 milligrams. So they had good reductions of alkaline phosphatase that were sustained out over that. Now here's the titration group, 5 milligram group. Now some of them had met this endpoint and they stayed on 5 milligram, but the majority actually had addition, and here they went out. So we then look at those that were up titrated. So the people that stayed on 5 didn't quite get they got the same level of reduction, but they didn't go further. This one, when you went to 10, they went right down and they got the reduction that the 10 milligram group got. So I think you can say going from 5 to 10, or starting with 10, were equally effective. They were the optimal effect in reducing the change of alkaline phos baseline. Now what about the actual alkaline phosphatase change? Here are all the alkaline phosphatase starting levels. Individual patients are here, and here is whether they went down or they went up. Well, here's the 0 point at baseline, and you can see that in the placebo group, they tended to go up over that 12-month period of time. Is that, you see pretty well? But look at the titration group here in orange. I get this thing to work. And look at the group at 10 milligrams. They tended to go down, no matter what your starting value was. You tended to go down. Down is better. Even if you didn't get to 1.67, down is better based on those curves I was showing you at the beginning from the global PBC group. So individuals really did very well in this drug in a way totally different than the response of the placebo group. So if we look at total bilirubin here, you can see that total bilirubin went up from baseline in the placebo over a 12-month period of time. It went down and then it gravitated. Here's your titration group, and here is your 10 milligram group. If we looked at other things like GGT, which your doctors use as a test to prove whether your alkaline phosphatase came from your liver, or might be coming from bone or gut, because there's 3 places in your body that generate this enzyme. So if your enzyme is up and your GGT is up proportionally, that means it came from liver. If your enzyme is up and the GGT is slightly up, it means that maybe there's a contribution there from bone or from gut. And we can ask and answer that question by having your alkaline phosphatase fractionated. We can tell exactly what percentage comes from liver, from bone, and from gut in one simple blood test. And for some people, that's important, particularly if you have bone disease, because that could be a source of alkaline phosphatase and be confusing. So you can lock in a little bit more specifically on the liver part. So here's the GGT, not changing in placebo, dramatically going down, and that is the surrogate for alk phosphate that would also decrease, that the decrease was the liver-based alkaline phosphatase. If it wasn't, the GGT wouldn't have gone down. ALT, this is the injury enzyme of your liver cells, and that went down. AST, the other injury enzyme, also went down. So it had that anti-inflammatory property that I mentioned. And then it also did something for immunoglobulins and cytokines. And this one, very importantly, is a highly sensitive CRP, which is a measure of total body inflammation. And the liver is one of your bigger organs, second only to your gut in size. When the liver is inflamed, that means the second largest organ in your body is inflamed. Believe me, the inflammation signals are going to be powerful, and they're going to be reflected in this. And this is our best evidence that with treatment, we knock down inflammation in the liver. Remember, I told you it was anti-inflammatory. How do I prove that to you? I do it with the enzymes I just showed you, and then I do it with this. And this is extremely interesting because it turns out your CRP, if you go, you have no liver disease at all, you go see a interventional cardiologist, where they want to put you as the lowest level of inflammation. Inflammation anywhere in your body has a correlation with cardiovascular diseases. So the less inflammation due to any cause whatsoever, the less cardiovascular disease risk you have. So this is a target not only telling us what happened in the liver, but it has reduced the risk of cardiovascular disease in anyone. Now, we have the long-term safety extension. People were asked, do they want to come off a placebo and be treated? And if they're in titration or 10 milligrams, do they want to continue treatment? And the vast majority said yes, 94 to 100% of people. Now, that's important to all of you because that's a person who's been on the therapy, who has had, the pros and cons. They take stock and say, can I hardly wait to get off this study and get back to my life? Or do I really want to continue this? And virtually everybody wanted to continue. Even the people that wanted to continue, some of them couldn't, and that's where some of the percentages decreased. But it was well tolerated. This is the patients voting to stay on the therapy themselves because it was well tolerated, and they knew what their individual results were. So here's the long term. Here's the 12 months I just showed you. Here's an additional period up to 16 months. And you can see that when we treated the placebos, zoom, they came down, the gray. So they got the benefit. We kept treating everybody else, and they got the benefit sustained. Now, how did we treat them? We treated them in a way that's in the package insert for the new approval. We started everybody at 5 milligrams. And we had everybody, even if you'd been on 10, you went to 5, you'd been on 5, you stayed on 5, you were placebo, you all went on 5. And at 3 months, not 6 months, you took stock of where the enzymes were, and then you up-titrated to 10. Okay? And that is what you're seeing before you. So the placebo group that was worsening, I showed you their alk phosphorus had gone up, their bilirubin had gone up while they were being observed in the first 12 months. Down they come, and they get the effect that you want. You get that? Now this is looking at the bilirubin response, and this is a little bit closer to baseline because not many people had abnormal bilirubin. which was part of the problem the FDA had in using bilirubin as a good measure for going forward with the approval. There just weren't enough data. Long term, in the phase 4 study, we'll have the data. So here's the Cobalt study. This is the one that we're enrolling. Now, this is placebo-controlled. That means you can be on URSO, but you have to have a little bit more advanced disease. And it goes from 5 milligrams to 10 milligrams, and so it's randomly assigned, and it has its endpoints. This is the trial that the FDA mandates be done to prove that what we just showed you is actually going to occur in a larger group of patients. No longer a trial, but an authorized therapy. So the efficacy summary here, we had consistent results in high-risk populations. The response was durable. It was clinically meaningful and statistically significant improvements in the markers of cholestasis and hepatocellular injury. That's your AST and ALT enzymes that you see on your laboratory test, and total body inflammation. Starting at the 5 milligrams is being used in the Cobalt therapy and is being used as the approval of the addition of this therapy. Now, if we look at adverse events, we have the placebo, the titration, the 10 milligrams, and the long-term safety extension, those people going out, some of them for 5 years that I've shown you, some of them are actually out at 8 individually, and then you have the long-term extension I just showed you is 16 months and counting because they're still in it. So if you look here and you look at serious adverse events, they were very few. And the adverse events were unrelated. The serious adverse events, they were unrelated to the disease and therapy. So we had infections, we had some cardiovascular things in people that had valve problems, et cetera. Now, if you look at the adverse events, that means anything. You say, doctor, I coughed, goes down as an adverse event during your 12 months. And so guess what? In 12 months, anybody, study or no study, placebo or no placebo, disease or no disease, is going to have a headache, about a diarrhea, a little nausea, a little this or that. There's going to be AEs. We all experience life. If you look at the one that stands out, it was itch. Placebo itched. And in fact, about 64% of the placebo patients had itched somewhere in their course of disease before they entered the trial. Titration itched, 10 milligrams itched, long-term safety extension had itch, but the lowest amount of itch was in the titration. And it allowed people to get past the itch before they went up to 10 milligrams, which was more inducting of the itch. Now, we also had some clinical hepatic AEs very infrequently, and these were in the patients that had a fairly advanced degree of cirrhosis. Let's see. So let me go back one and look at high-density lipoprotein and low-density lipoprotein. That's how you get your cholesterol fractionated. High-density lipoprotein is the good cholesterol. Low-density lipoprotein is the bad cholesterol. And what you found here is a slight decrease that stayed within the normal range in the vast majority of people. That was the HDL change. The LDL change was a slight increase that then went back to baseline. So the actual cardiovascular risks imposed by this we believe to be negligible. And remember, elevated cholesterol is part of primary biliary cholangitis. When you have it, the disease tells the liver to make more cholesterol. And it tends to make more HDL, not the bad cholesterol. So many of you have probably been told by your doctor you have high cholesterol. And I hope that many of you have been shown between the two that the majority of your rise is in the high-density lipoprotein, the good stuff. It doesn't necessarily, as a disease, cause the bad cholesterol. So the itch is common. It's up to 70%, even in those that entered the study that had a previous history of it. It ranges from mild to severe. It may resolve with the progression of liver disease, and we don't know what actually causes you to itch. And we really have sort of an unknown mechanism of action in terms of what to do about it. But we do know that the majority of patients had pruritus at baseline. I've shared that with you in all 3 groups of treatment. We know that the OCA reduced the alk phos level. The pruritus was the particular principal adverse event. I showed you that at 25 and 50 milligrams that they didn't need that much to get the biochemical event. They actually caused a lot more itch. So we kind of knew that from some studies. I didn't show you that. And we need to have some further studies. But the background here is, despite the common fact that pruritus can occur, that discontinuation due to pruritus was very low. In the titration group, it was 1 patient. In the 10 milligram group, it was a few patients. That's why we want to start with titration, because it's a much more tolerable thing to go for several months at 5 milligrams before increasing to 10. And this is, I'm not going to go into, but this was how the patients rated their own itch. It's called the visual analog score. If we look at the score, it really, all these lines are almost superimposable, except for the placebo that was not, doing well in terms of itch. And this is one of those build slides. And this is that the treated patients had either no pruritus, the majority of them, and they didn't require, in many cases, any treatment at all for the pruritus. It was something very mild, just in passing it was mentioned. So you can see the discontinuation rates due to pruritus there. And then you can see that pruritus could be interrupted, you interrupt the therapy, go to every other day, or use something like cholestyramine or closovalum or other bile acid resins. We had everything available to us as investigators for this trial, but actually a large number of patients that had itch didn't require any therapy whatsoever. So the pruritus management, I'm not going to really go into. That's a little bit more detail, but I want you to be quite aware that we have a lot of ways to manage pruritus. And the management strategies were all utilized, and the ones that stand out as being more unique to this drug is an interruption of the dosing interval. And you only received, concomitant medication, and then you received some medications along with interruption or dosing interval changes. So we have a lot of tools in the toolkit to handle pruritus. So its summary is that it was the most frequent side effect, and it is the most frequent side effect in PBC in general, along there with fatigue. It improved over time and reduced pruritus-related discontinuation. And this titration will delay the time to pruritus. In some patients, it will prevent it. And we have multiple management strategies if someone does develop pruritus. So the overall safety summary is good. Just going to leave it at that because I want to quickly share with you data presented last November, because we're talking about new therapies, of an additional new therapy. This one is coming out of the NGM company, a biopharma company in California. This one is targeting, in this very complex slide, I put it all into this little box. This is targeting this process, and it's targeting specifically the ability of this enzyme to make those bile acids that are then retained as cholestasis and are harmful. Now, when you make a bile acid, you have something released into the bloodstream called C4. So you make a bile acid, you generate some C4. You make a lot of bile acids, you generate a lot of C4. So measuring C4 allows you at the beginning and during treatment to know whether you've done what you think you're doing, which is to knock down the production of bile acids. They had a placebo group. They had a subcutaneous injection of 0.3 milligrams and a subcutaneous injection daily of 3 milligrams. So this is an injectable agent, but see, it's only over 28 days. It's basically a 4-week study. And what they found here is alkaline phosphatase change. Here's your placebo, no real change. And here are your two groups, the 0.3 milligrams and the 3 milligrams, out to day 28, and you stop the drug. So guess what happened? Here comes the alk phos roaring back and going back to the baseline. So it was imposed by the drug, but it didn't, reset the thermostat. The alk phos was going to come back when you stopped. You look here at the absolute changes. These are in numbers of the units. So that meant that you here had about 20-point drops. So if you were 225, you dropped to 205. If you were 200, you dropped to 180. So it's the absolute changes. But remember, it's only 28 days. It's a proof of concept. If we look at the ALT, the injury enzymes, ALT and AST, and that GGT, which is the corresponding marker of alk phos, you can see that in the placebo group, before and after, before is in orange, after 28 days is in blue, no changes. You look in the treatment groups, and you see decreases in ALT in both arms, decreases in AST in both arms, decreases in GGT. However, the size of the study in 28 days didn't make all of these statistically significant changes, but they were all in the right direction. I think we would agree with that. If you look at the change in serum C4, that marker of whether you've done what you wanted to do, you didn't do anything in the placebo group. If anything, it slightly went up on average. It came down at 0.3 milligrams, and it plummeted at 3 milligram dosing. So as they move forward with this, they're probably going to use a higher dose. This is the change in the bile acids. Won't bore you with that. The C4 said it all. And they had a number of side effects that were fairly equally distributed among the placebo-treated patients, meaning they weren't due to the drug, as well as in the treatment arms. And among the side effects was not itching. So I have covered the waterfront here, and I know that much of what I've said is something that you're aware of, but I hopefully have clarified some of the issues for you, that we now have, for the first time in 35 years, the opportunity to take the 35 to 40% of individuals who have had a partial response to URSO or who have remained intolerant of URSO and to treat them with something where about 50% or greater of that population will move into that majority with a life expectancy identical to a population that does not have liver disease of any sort. And that with cirrhosis, treatment, an early phase of cirrhosis can lock that in to a superb prognosis. And so I'm very happy to be here. I thank you for your attention. I'm going to stay throughout and be here through lunch and be happy to answer any questions. Can you stop here? Okay. So there are a couple of questions here. One of them is, do individuals start to lose response to URSO over time? They tend not to unless by the natural occurrence of getting increased weight over time, you start to fall beneath